Welcome and thank you for watching this recorded webinar. Before we get started, I want to remind folks who need APA continuing education credit, you must have registered and purchased a post-test. You must pass with a score of 75% or higher, and you will be given 3 attempts to pass. And once you pass, a CE certificate will be automatically emailed to you. We also ask that you kindly complete the program evaluation. Links to the program evaluation and post-test are in the show notes. Thank you for considering the Multicultural Counseling Institute as part of your professional development. Okay, so Dr. Reddick is a pediatric neuropsychologist at Dell Children's Medical Center and serves as an assistant professor of neurology and pediatrics at Dell Medical School at the University of Texas at Austin. She specializes in conducting both inpatient and outpatient neuropsychological evaluations for pediatric patients with acquired and traumatic brain injuries, brain tumors, cerebrovascular disease, oncological conditions, hematological conditions, and neurodevelopmental disorders. Dr. Riddick is also committed to evidence-based and culturally responsive neuropsychological practice in her clinical, research, and scholarly works. She is consistently working on her own cultural humility, embedding culturally responsive practice within training, and speaking on how to translate theory into practice. So, without further ado, Dr. Reddick, I will hand it over to you. Let me go ahead and share, stop presenting.
Thank you very much for those kind words. I'll go ahead and get my screen shared now. All right. And can I have some confirmation that you are seeing the screen?
Yes, we can see the screen.
Okay. Lovely. Well, thank you so much for that warm introduction. As Dr. Sun said, my name is Dr. Iman Khwaja Reddick, and I am very excited to be here with you all. And I want to start off by saying thank you for being here and for your continued commitment to learning and refining your own knowledge, skills, and attitudes around considering cultural diversity in your clinical practice. Today, I will be presenting on culture, a foundational variable in neuropsychological and psychological evaluations. I want to start by acknowledging and extending my gratitude to Dr. Jack Sun. I appreciated the safe space you created during our podcast interview and also greatly appreciate this opportunity to speak at the Multicultural Counseling Institute. I also want to acknowledge all those who have come before me and have paved the way for cultural neuropsychology practice. Regarding a position statement, the views expressed in this presentation are by me and do not reflect the position of my place of employment or the Multicultural Counseling Institute, its CE programming, or other instructors. This information is being presented from my cultural perspective, and that includes considering my diversity variables. For context, I'll share some of those with you today. So broadly, I'm a cisgendered heterosexual female. My pronouns are she, her. I identify as an American Pakistani, and I identify with both American Western individualistic cultures as well as Pakistani Eastern collectivistic culture. Regarding language, I have balanced bilingualism in English and Urdu, and I can read and understand some Arabic. Some other variables that intersect and impact my perception and experience of the world include growing up in rural Ohio, where my mom was an immigrant at the time and a physician. I had some interesting and challenging experiences growing up in rural Ohio with my particular diversity variables. So for context, I was raised in a Muslim household and came from a non-nuclear family and attended Catholic school while I was surrounded by the majority who were white, blue-collar, Christian, and Catholic nuclear families. So needless to say, early on, I developed a heightened awareness of similarities and differences between myself and the majority. Lastly, I do want to acknowledge some areas of privilege that I have. I come from a family where most have completed higher education. I myself am a doctor and am in a higher socioeconomic bracket compared to some of the families that I serve. And I'm married to a white American male, which has afforded me certain privileges at times that might be subtle to others, but are evident to me considering some of my lived experiences. So with that in mind, just keeping that at forefront, thinking about your own diversity variables and how that might impact your perception and how things might be presented in terms of the case that I'll review at the end. Regarding the learning objectives for today, by the end of this presentation, you will be able to describe diversity-related concepts, including cultural neuropsychology, culture, acculturation, intersectionality, and language and multilingualism. You'll be able to understand and examine your own cultural humility, as well as be able to explain the competency model. And you'll be able to describe the eclectic framework and list all of its components. And lastly, you'll know how to systematically implement the eclectic framework to support culturally responsive practice based on your specialization. Let's begin with reviewing some diversity concepts. I will start with defining the subspecialty of cultural neuropsychology, because that's the lens from which I practice and from which I continue striving to improve my skill set in. Cultural neuropsychology is a systematic study of brain behavior relationships within the context of engagement in specific cultural practices that organize the development, maintenance, and revision of cognitive schemas and behaviors, and which reveals the relationships between sociocultural factors and cognition. That's a lot, but in summary, what that means is that an individual's cultural practices inherently influences and shapes their cognition, their belief systems, their perceptions, and schemas of themselves and the world. So, culture shapes and impacts cognition, and cultural neuropsychology takes that into account and conceptualizes from that lens so that the most reliable and valid data, conceptualizations, and interpretations can be made. So what is culture, this incredibly influential and foundational variable? Well, you all know what culture is, and it can be defined in various ways. A singular and broad view of culture is that it's a shared way of life for a group of people. Maybe a more nuanced, operationalized definition is that culture is a worldview that's born of learned and transmitted belief systems and value orientations that influence customs, norms, practices, and social institutions. And that includes psychological processes such as cognition and behavior, and organizations such as educational institutions. Additionally, with globalization, there's been a large interaction between different cultures and the impact on economic, political, societal, technological, and ecological elements. And that actually highlights that culture is not always necessarily stable, that it's in constant evolution. So with that being said, it's clear that culture is a broad and complex concept that impacts every day of our lives. Moving to acculturation. Acculturation can be broadly defined as the similarity of a client's culture and experiences and adoption of the mainstream culture. So let's break that down a little bit. It's essentially a multidimensional process that involves the confluence among heritage culture and receiving cultural practices, values, and identifications. So as you all may know, there are 4 levels of acculturation. We have assimilation. This is when an individual adopts the receiving culture and discards their heritage culture. Separation is when the individual rejects the receiving culture and retains their heritage culture. Integration is when the individual adopts the receiving culture and retains their heritage culture. And marginalization is when the individual rejects both the heritage culture and their receiving culture. Now, a patient's level of acculturation can significantly impact test performance. Using language as an example, level of language proficiency in the dominant culture can impact test performance, particularly on verbal tests. So thinking about what this may look like in context, an average vocabulary score would have a different meaning for a patient who was born and raised in the US compared to an average vocabulary score for an immigrant for whom English is their fourth language. So we need to make sure we take the cultural aspect into account in our interpretations. And that's why it's a major variable to consider in each aspect of our evaluations. Another concept is intersectionality. Intersectionality captures the multiple aspects of culture or identity and how they interact with one another and with the world. So in other words, we cannot view the various aspects of our identity in separation or in isolation. Our identities intersect in unique ways at times, sometimes to help explain or contribute to how certain groups experience privilege, while other groups are excluded from certain privileges because of these aspects of their identity. So for example, someone who is a person of color, a woman, and maybe multilingual may not have the same access to healthcare or education as someone who might be from the dominant culture, which might be someone who is white, English speaking, and male. So these are variables to consider when we are working with patients and families and noting what they're coming into the room with. The final diversity concept that we will review today is language. Language is an important and core aspect of cognition. Language influences how we think and perceive stimuli, how we process information and respond, not just verbally or non-verbally, but even regarding our processing speed and reaction times. Language affects cognitive processes in three major ways. One, by differentiating where attention is directed. Two, by making some forms of social communication patterns more accessible. And three, by affecting the thinking style used to approach novel situations, whether it's more of a top-down approach, bottom-up approach, gestalt, or looking at the details. That can be influenced by culture and by the language of that culture. So putting these three major concepts together, language is a core aspect of cognition. Cognition is shaped by culture, and culture influences and shapes language development. So culture is a major and foundational variable in cognitive and language development. And as you can see now, it is all connected. Now, some concepts related to multilingualism and language proficiency. BICS stands for Basic Interpersonal Communication Skills. Some of the examples of this include being able to socialize with peers and discuss your day-to-day. Those are examples of context-dependent conversations. And these skills can typically develop within 2 to 3 years of practice. Then we have CALP, and this stands for Cognitive Academic Language Proficiency. And these are skills that are required in academic settings and involve higher order cognitive strategies. These conversations do not have to be context dependent, and it takes more time to learn this level of language proficiency, on average with about 7 to 10 years of academic exposure. So putting this into a case example, you may have a patient whose first language is not English, but English is their second language, and maybe they're at a BICS level, or maybe they're at a CALP level. These are some details that we need to learn about when we're trying to determine what tests to administer, and even taking a step back if we are the appropriate clinician to be conducting the assessment. So clearly culture is important, but why does it matter in assessment? Why is it important for us as psychologists and neuropsychologists to understand the influence of culture on cognition? Can't we just use culture-free tests? Well, let's talk about it. There is this universality view of cognition, and that's what underlies this concept of culture-free tests. But that's not necessarily how things work. Because when we dig deeper, as we've done so far today, we're able to see and recognize how influential and foundational culture is to shaping cognition and language development. And with that understanding, we can recognize that our standardized tests measure cognition and serve as cultural devices that assess abilities that are valued by the culture in which they were developed. So our standardized instruments are in fact also cultural instruments that reflect the values, knowledge, and experiences of our Western educated society. And at times this can lead to questionable construct validity and generalizability related to racially and ethnically minoritized groups. For example, research has demonstrated that level of acculturation significantly affects test performance on neuropsych tests. And this has been demonstrated in Black African Americans, Hispanics, mixed Asians, and Middle Eastern populations. So a primary responsibility that we have as ethical, culturally, and socially responsible clinicians is to consider the potential influence of these factors on the clinical interview, test selection, test administration, data interpretation, and the feedback sessions. So we need to know and understand when the norms were created, who was included in that sample, if normative data was stratified in ways that best capture the demographic factors that contribute to test performance, or how closely our patient resembles the sample. And currently our tools are not the best at considering patients' cultural and diversity variables. And that's why we as clinicians are important factors in conducting these evaluations. We need to use our skills to look beyond the numbers, to incorporate additional data points to put together a truly comprehensive picture of the patient's functioning. And to do that, we need to be constantly working on and evaluating our own cultural humility and responsivity. Cultural competence is defined as active engagement in a lifelong process that involves the individuals entering into an ongoing basis with patients, communities, colleagues, and with themselves. So cultural competence is a process rather than a discrete goal with an endpoint. And it requires cultural humility from the individual. That includes engaging in self-reflective practices, self-critical processes as lifelong learners and practitioners. It can be hard to look in the mirror, and I think that's something that we all need to do every once in a while, and that's what helps us not have this universality view. So Dr. Diaz Santos and Dr. Hugh wrote a chapter called Cultural Competence Guidelines for Neuropsychology Trainees and Professionals Working with Ethnically Diverse Individuals. And they outline some guidelines that help maintain cultural humility and responsiveness when working with ethnically diverse and minoritized populations. Broadly, these are know yourself, know others, know your assessment tools, and know your advocate role. So knowing yourself includes knowing your own diversity variables and how they intersect and what implications that may have in various settings. What power do you hold? What areas of privilege do you hold? Where are you minoritized at? And how does that impact your perception of the environment? Knowing your stereotypes and belief systems. Also, clinically, what are your strengths and what are your weaknesses? Do you need to consult out or refer out? And what resources may you have to offer the patients and families that you're serving? So increasing your own self-awareness is imperative overall, and especially because it decreases that likelihood of assuming that your culture and your worldview are universal. Knowing the other. So what are the patients' and families' diversity variables? What are their values and belief systems? And how do those variables impact cognition and performance? What is their experience with mental health professionals? What are they willing to share and not willing to share? Uh, all of those pieces play into who is walking into the room and who we're assessing. So we need to have a good understanding of that. And as we briefly talked about, know your assessment tools. Thoroughly reviewing those materials and the literature to see what's being used, what populations it's being used with, who's doing these evaluations and how are they doing it? What validity concerns do they have or don't they have? And how are they contextualizing their data with our limited tools? I think something that comes to mind for me is that here in my practice, I have Spanish speaking patients. Sometimes I have access to a trainee who speaks Spanish and we're able to administer some Spanish measures, but I have to do my own due diligence and review those measures and look at the literature and consult with my bilingual colleagues so I can have a good understanding of how this should be administered, scored, and interpreted. And sometimes it comes up that these measures are standardized in a certain way and administered two different ways for different reasons that some of our colleagues who are working with bilingual and multilingual patients have found to be more effective or more informative in some way. So it's on me to do that work, to learn about what's going on in the field so that I can best support the patients and families that I'm seeing, and if appropriate, refer out, but of course, always getting consultation. And lastly, we are focusing on our role as an advocate. So that involves having an understanding that doing culturally responsive work doesn't end with the evaluation being done. We need to recognize that our patient may not have the resources to navigate the healthcare system or may not have the personal social system to execute the recommendations we provide. So we need to be ready to advocate for the patients and families in any way that we can or provide them with appropriate resources. And if that's not the case, maybe we go to the next level and bring it up in one of our team meetings to say, I'm coming up with this issue where families don't have access to XYZ. What can we do to remediate this so we can provide equitable healthcare? So now that we've discussed diversity-related concepts and cognition, the importance of considering culture in our assessments and our ethical duty in committing to cultural humility and responsive practice, let's talk about a framework that helps us account for all of those factors. The eclectic framework. This was developed by Dr. Daryl Fuji, and it works to contextualize the impact of culture on neuropsychological evaluations, and of course can be implemented within our psychological evaluations. And this framework specifies how individual facets of culture can impact test performance. And that further helps us understand our culturally diverse clients and to be able to correctly contextualize the data. This is an incredibly rich framework that I will just broadly touch on. So I strongly encourage you to read Dr. Fuji's manuscript in which he introduced this framework. So eclectic is an acronym, and the first E stands for education and literacy. And we aren't simply talking about grade, school, and special education services, but about the quality of education and the culture of the individual's educational environment. What was the level of education that's acquired, and is that typical for that culture? Or what about those who don't receive formal schooling and instead learn their skills from the environment? Our tests measure skills learned in formal education, and our measures wouldn't be a valid representation of cognition or skills for those individuals. And notably, one of the most robust findings is the impact of education on neuropsychological test performance, namely with education being very highly correlated with vocabulary and reading levels, which in turn are both highly correlated with intelligence. C stands for culture and acculturation. Here we are thinking about the patient's beliefs, values, and worldview. What are their family's cultural norms, including for interacting with healthcare professionals and mental health professionals? We also want to consider values and practices that may be related to individualistic versus collectivistic societies. L stands for languages spoken and English proficiency. So first and foremost, neuropsychology and most psychology evaluations are primarily language-mediated processes. Thus, accurate data collection relies upon the patient's language proficiency for both expressive and receptive language skills. So a major first step, if the patient is bilingual or multilingual or monolingual, is assessing the patient's English proficiency. And doing so can determine if the patient can actually be tested in English, if an interpreter is needed, or if you need to refer out to a bi or multilingual provider. These factors will also influence test interpretation. And now, establishing language proficiency is complex, but it can be done. So sources of information to include self-report, demographics, for example, generation that the person is in the US, their age at immigration, their years of education in the US, education level, their proficiency in their native language. We also want to be mindful of and listen to their responses to open-ended questions. We can give some formal assessments of skills in English and their native language if those are available, and also do some testing that are correlated with English proficiency levels, such as a verbal fluency test or the Boston naming test. Ideally, patients should be evaluated by neuropsychologists and psychologists who are fluent in their primary language. However, when that's not possible, trained interpreters can also be used, but we also need to consider that when in our norms and interpretation. E stands for economic issues, and as you may know, low socioeconomic status and poverty have been associated with lower cognitive functioning, difficulties in aspects of language, memory, processing speed, and executive skills. And studies have shown that social aspects of economics have a significant impact on cognitive development, even when controlling for parent education level. So, for example, you may see a patient who stopped going to school because they needed to work to provide financial support for their families. Thus, financial stress and socioeconomic status are issues that are important considerations that play into our data interpretation and conceptualization. The second C stands for communication style, which is essential for obtaining accurate information about the patient. Now, thinking back to your clinical interviews, when you're conducting them in the same language, that can be difficult at times. And sometimes you may find yourself asking the person the same question a couple of different ways and getting different answers. So however many times you ask the patient to verbalize, things can get kind of lost in translation, literally. And there's a whole additional layer of complexity when the patient and examiner don't speak the same language. It's also important to consider any impact of using an in-person or virtual interpreter. A few things to consider include confidentiality, the sex or gender of the interpreter, the family's comfortability with sharing their medical information with someone who is not a medical professional, and even dialect, just to name a few. Those pieces cover verbal communication, but it's also important to consider visuals and how they may support or take away from conversation, understanding, and mastery. For example, I will always remember I had a patient's parent who frankly informed me that they had ADHD and dyslexia and needed a lot of support when discussing education and recommendations, particularly regarding her child's cognitive functioning. So I trialed a couple of different things, got her feedback, and as we were talking and I was providing her with education, I was able to get immediate feedback for her for what worked and what didn't work. And that way I was able to really ensure she had good mastery of what we were talking about. And that really gave her peace and gave me peace of mind that she understood what was going on, knew how to advocate for her child in the school setting, and knew how to support her child at home once they discharged from the hospital. T stands for testing situation, and that is the patient's comfort level and motivation regarding standardized testing. To some, neuropsychology and psychology evaluations can be a bit strange and uncomfortable, and motivation may also be a factor in test performance. And as you know, we need sufficient effort to produce valid results. And so some individuals from different cultures or countries may not understand the weight that the evaluation carries, and are unclear about how completing our evaluations helps them reach their goals. So that involves an additional conversation and making sure that those pieces are connected so they can understand why we're doing what we're doing and why we're asking them to perform this specific evaluation in this way. All right, and I stands for intelligence conceptualization. A culturally diverse client standards of intelligence may differ from Western notions of intelligence, which tend to emphasize reasoning, problem solving, understanding complex ideas, and most notably, learning quickly. So response speed is something we need to be mindful of. And for most Western educational systems, intelligence is equated with quickness. However, that's not necessarily the notion or the assumption amongst all cultures. So when we are measuring processing speed, or we are engaging with a patient that is from a different culture who from which they are really focused on taking your time with your answers, thinking through all the options and providing a mindful response, we need to make sure we don't just chalk that up to slow processing, comprehension issues, or whatever it may be, but really consider the culture from which they're from. C stands for context of immigration, and that's important to know because it helps us contextualize how the patient fits within his or her culture of origin. It gives us insight into understanding immigration selection bias, and the reason for immigration can also shed light on some other issues. And ultimately, understanding an individual's context of immigration provides insight into their life experiences. So that is a broad overview of the eclectic framework. We've also reviewed many concepts related to diversity and culture. And now we are prepared for the next step, which will be systematically implementing the eclectic framework to a clinical case, so that we can see how to appropriately consider culture in our evaluations.
Now,
So,
before we go on to
yes.
this case example, why don't we just take a quick pause here for some questions? Just because I know there are some concepts, and I know for me, when I was thinking about the eclectic model, I had some reactions as well. So, if y'all have any questions, since we have an intimate group here, feel free to just chime in, or if you like, you can type your question in the chat screen. And as we're waiting for questions, I guess more of a comment, but maybe some ponderings as well. I love that you mentioned, processing speed as something that we highly measure. It's on the waist, and so when we're thinking about assessments, and it never occurred to me, oh yeah, culturally we're told, hey, you got to think fast, and then be able to think fast and express quickly your thoughts. So that was such a sort of aha moment for me as we're
Mhm.
just talking about the influence of culture.
Yeah, I think that there are some cultures that, similar to our Western culture, that have an emphasis on speed and how quickly you can do things and being fast, fast, fast. And, there are some positives to that, but we sometimes don't see the other side of the coin where taking a slow, thoughtful, mindful approach is also helpful and is also a sign of intelligence. So I think nowadays, some people are having their mind open to that as well. And that's obviously something that we need to consider when we're working with patients and families. But when we're thinking about this from the neurological perspective, like if we have a patient that has a brain injury or is getting chemotherapy and they've had impact from their treatment, we actually do see slow processing speed as a late effect or as effect of that medication impacting those pathways. So those are also some nuances that might need to be teased out when we are considering culture, but also the neurological presentation.
So Dr. Hassar, do you have a question?
Excuse me. Yes. I think it is obviously it's so important to think about how what intelligence means in someone's culture and what it is valued as intelligence when we're testing or selecting tests and interpreting data. And I'm wondering how, and maybe you'll get to this, but then we use that to inform recommendations that are going to be used within this Western society that values that speed and those sorts of things. Like, how do we balance that? Because ultimately, that's what a lot of our patients are looking for. So I'd be very curious to hear your thoughts on that.
Wow, Dr. Hassara, that is a lovely question. And, I don't know for sure all the answers. And I think that I've had this come up and with a particular family, and the approach to conversation was more storytelling. And in the school system, that is they want more efficiency, get to the point. We need you to say what you want to say. And that was something that was hard for that individual to kind of work through. And I think part of it, as in the chapter in terms of training neuropsychological competence in cultural sensitivity, is knowing your role as an advocate. So I think part of what we do in our role as advocates in writing these recommendations is kind of saying, this patient is able to do best or demonstrate their mastery once they have adequate time to process their thoughts and get their words out. So I think maybe something we can try is providing some context as to why we're giving that recommendation and tying it to culture, but also the neurological and cognitive component as well. But other than that, I've been able to do that with some of my patients here because I have a very multicultural population here. But I am interested to hear anyone else's thoughts regarding that question.
As you were talking, I had the same thought about, this is the place where we can be the advocates for our patient and to kind of bring that awareness to school staff or personnel, seeing that patient more holistically rather than just their disease or disease process and how that impacts everything.
Definitely.
Yeah. It's like advocating for the client, the family, and also putting that on the report. Making it clear. Yeah. Yeah. So why don't we go ahead and move on to the clinical implementation piece?
All right. So details from this case have been changed, revised, or completely deleted, but there's enough information to give you all a good background, and that's done so for confidentiality, obviously. So starting with a little bit of background for this patient, was a 15-year-old right-handed Sri Lankan female who was born full-term in Sri Lanka. Her early language and motor milestones were on time. She wore glasses for nearsightedness. She was mostly healthy from a medical perspective, and her academic, behavioral, emotional, and social functioning were all within normal limits. No concerns there. So now we're going to use the eclectic model to support information gathering as well as to support our neuropsych test administration, selection, and conceptualization. I'm going to start a little bit out of order just for the first one, and then it'll make sense as I continue. But starting with language. So the patient's first language was Sinhala, and her second language was English. She started learning English in kindergarten, and per her and her mother's report, she was fluent in both languages. She spoke in Sinhala to her parents and family members and spoke to her friends when she was in the United States in English. She also reported watching television, movies, listening to music, and thinking about her feelings in both languages. And her language preference really depended upon the context in which she was in. Now we'll go in order, moving on to education and literacy. The patient had bilingual educational instruction from kindergarten through 8th grades in Sri Lanka. Notably, Sri Lanka has some of the highest literacy rates in South Asia. Specifically, it has the highest reported youth literacy rate in South Asia at 98.77%, as compared to India, which is at 89.66%, and Bangladesh, which is 83.2%. Sri Lanka is also one of 2 countries in South Asia that is recognized by the UN as achieving, quote, high human development. Also, the education system in Sri Lanka was and continues to be shaped and modeled after the British system due to their prior colonization. Additionally, languages of educational instruction include Sinhala, Tamil, and English. Now, there are also socioeconomic factors at play in the schools, such as overcrowding in some and competition, and this tends to be based on urban versus rural environments. So those are some factors to consider when we're thinking about the quality of education or the culture of the educational system. Okay, pausing there briefly. All of that background information about Sri Lanka and its educational system is knowledge that I learned on my own so that I could better understand the patient's educational instruction and the quality. I did not rely on the patient or her family to teach me about their system. I did, of course, get background information so I knew that they're from Sri Lanka and where they lived and all those types of things, but I took it upon myself to do the research so that I could appropriately inform my evaluation and determination for testing. Back to the education piece. As I mentioned, the patient received bilingual educational instruction for K through 8th grades, and then the patient and her family immigrated to the US. And upon her arrival, she started 8th grade. And at the time of the eval, she was in 10th grade and was earning A's. She was not in any English as a second language or English learner classes. Okay, so that's a lot of language-based information, but it's important when we're thinking about this particular case, right? So let's recap the qualitative information we have so far. The patient's first language is Sinhala. She started learning English in kindergarten and then received bilingual educational instruction for a total of 9 years. She's now in English-only instruction and earning A's. In my direct conversations with her, she appeared fluent and had the slightest accent that could easily have been missed. So putting that all together, she is really a good example of being a successive language learner, which actually produces strong bilingualism. Moving on to culture and acculturation. The patient described an integrated level of acculturation in which she adopted aspects of the receiving culture and maintained aspects of her heritage culture. Socially, regarding this new space that she was functioning in, she described making friends as easy, and she was engaging in typical adolescent girl activities. Also, her faith was very important to her. Her and her family practiced Catholicism, and she was, while she was hospitalized, she was making sure she regularly met with a chaplain. There were no reported financial issues, and not that I was aware of or that was shared with the social worker that the family shared. Mom was an accountant when the family was living in Sri Lanka and was now working in data entry, and the patient's father worked in export management. Regarding communication style, so I primarily spoke to the patient and her mother as she was the only parent at bedside and father was taking care of other siblings. And her mother had a similar language history and also reported a preference for speaking in English with not having an interpreter. Just to be safe, because we're talking about neurological conditions, cognition, those types of higher level concepts, I did have access to a virtual interpreter that I kept in the event we needed to better support understanding each other and to support our communication in general. But throughout our interviews and education sessions and feedback, I did do some teach back moments or just tried to get an understanding of what mom heard, and what she was able to communicate was right on exactly what I had said. So I felt that comfortable with both of us having good understanding of each other. And then with the patient as well, she spoke, as I mentioned, fluent English, but I did keep access to a virtual interpreter with me in the event we needed it, especially during testing. So given the patient's educational culture, both in Sri Lanka and now in the United States, she was very familiar with standardized testing. So that wasn't a new experience to her, and she actually thrived in that area. And relatedly, in terms of the intelligence conceptualization. So based on my clinical interview with the patient and her mother and understanding the education system, I learned that they did value higher education in similar ways and had a similar intelligence conceptualization to what we have in the West. And just as an example that was so unique and made sense for this patient, she was so dedicated, she would put herself to sleep around 9:30 p.m. and wake up every day, even on weekends, at 4:30 a.m. to study for college readiness exams. So she wanted to become a pediatrician, and she was very dedicated and very focused on her education, and did a very good job in terms of understanding what was going to be expected of her for the testing situation. And lastly, in terms of context of immigration, the family had immigrated, they reported simply to provide their children with more opportunities. So now I will give you all some medical background to describe the patient's hospital course, and then we'll talk about the neuropsych evaluation. So briefly, the patient had recently been diagnosed with T-cell lymphoblastic leukemia and started on chemotherapy treatment. She had completed the induction phase of treatment, and that included the administration of methotrexate, among other medications. And she was at the time in the consolidation phase when she had multiple hospitalizations due to being very, very ill. The last hospitalization she had, which led to me seeing her, resulted from bacteremia septic shock. Now, bacteremia is when there's bacteria present in the bloodstream and the bacteria multiply and spread, leading to a body-wide infection and then to sepsis. And she had septic shock, which is the most severe form and can lead to dangerously low blood pressure and cause organs to fail and is ultimately life-threatening. So she was very, very sick, had altered mental status, cognitive changing, and over time, significant physical deconditioning. She was medically managed on the floors, and once she was relatively medically stable, she transferred to the inpatient rehab unit where I got to see her. So I went on to conduct my clinical interviews and my neurobehavioral status exams, and once it was an appropriate time, I conducted a targeted inpatient neuropsych evaluation. So let's talk about the testing approach and reliability and validity and how I was going to go about conducting a culturally responsive neuropsychological evaluation. So most obviously, I needed to consider the fact that the patient spent most of her life in Sri Lanka. So notable considerations included her bilingualism, the quality of her educational instruction, her culture, family values, life experiences, and the quality and level of exposure to Western educational materials, values, and expectations. And as you saw, the eclectic framework helped me gather that information and take it into account and apply it to testing. And recall, we talked about the patient's educational history, language history, and conceptualization of intelligence and familiarity with testing. And granted, the tests I had access to did not include individuals from Sri Lanka, but there were other similar factors. But regardless, this was a major piece to consider. But overall, when we put all the data together, I was able to get the best tests that were available to assess her cognitive functioning in the context of her having received bilingual educational instruction from K through 8th grades in Sri Lanka and English-only instruction in 8th through 10th grades in the US. Even with those considerations, it's possible that some scores were an underestimate and or reflected a true deficit when compared to fully Western educated students that comprise the majority of the normative samples for our standardized measures. Nevertheless, the results provided the best estimate of her functioning in English at that time, and importantly, knowing all that background and context information was definitely going to help me with contextualizing the data. So a very brief overview of scores. First, I administered a sight word reading and pseudo word decoding tests because those tend to be good estimates of premorbid cognitive functioning in English and would give me hopefully deeper insight into aspects of her English language proficiency. So as we discussed, those measures are nice proxies to incorporate into the additional information you've gathered regarding language history and getting a comprehensive picture of the patient's English proficiency. And the patient scored in the average range on both of those tests. So considering the qualitative information that I've gathered and the quantitative information that I had also had, I felt comfortable proceeding in English for all my testing. Overall, most of the patient's scores were broadly normal for her age, and an estimate of her intellectual functioning was in the low average range. She did show some nice cognitive strengths. These were scores in the 16th to 84th percentile in on most tests of attention and executive skills, verbal reasoning and memory, and visual spatial reasoning. She also showed some cognitive weaknesses. These were scores at the 5th percentile and lower in processing speed, fine motor speed, and dexterity, as well as visual spatial abstraction and construction. But kind of putting it all together, I saw the greatest cognitive impact on her processing speed and fine motor skills. And that tends to be consistent within the acute impact of chemotherapy treatment, specifically white matter injury and inflammation. And I would expect those cognitive weaknesses to improve over time, but keeping in mind that she's at risk for cognitive late effects given her treatment needs. And based on the language piece and all of that information digging that I did, it was clear that this was not a language issue in terms of testing perspective. I then conducted feedback sessions with the parent and the patient individually. And for each feedback session, I needed to consider the patient's and her mother's diversity variables, their values, their health literacy, and the best means of communication. Overall, the sessions went well, especially with the patient. She had a really nice insight and understanding and a very positive outlook. And the feedback session went well with mom, but it was challenging for her to hear about the patient's cognitive weaknesses. She was excited about the cognitive strengths, and that really reassured her, but hearing about the weaknesses that were not typical or normal for her child was difficult. So we took some time to process her emotions and understanding, but this was the first time that she heard about neurocognitive acute or the potential for late effects of treatment. But the fact that her daughter was going to get ongoing monitoring, that she would have periods of recovery, and that she would have the support she needed really seemed to kind of give her some peace. And I think something that we talked about as well when we were processing is that it's difficult for families to hear that their child has cancer and then to think that the life-saving treatment results in an acute or long-term change to their brain and subsequently makes their functioning just different for the rest of their lives, and it's almost like they can't get away from it. But that led us into a conversation about supports and resources and community and what that looked like for the patient and her family. And that was a really fruitful conversation, and I left feeling really excited that the patient's mother felt like there were some ideas and there were some places that she could have a safe space and support. But overall, with this case, this provides an overview of how to systematically implement the eclectic framework to conduct a culturally responsive neuropsychological evaluation. And that ends the clinical case presentation piece. And I have one other piece to this presentation, but I'm happy to take a pause here if you think it's best, Dr. Sun.
Sure. Why don't we, do y'all want to pose some questions, or do we want to go ahead and just finish out the last part? Well, why don't we go and finish out the last part, because we only have
Okay.
technically about 3 minutes left.
Oh my goodness. Okay.
Yes.
I apologize. I can speed through
That's
that.
okay.
This is just something about, I guess, more me and my culture and how I've been able to celebrate my some of my diversity variables when working with patients and families. And so I mentioned before that I identify as an American Pakistani, and that's important to me. And I identify with seemingly individualistic cultures, but also collectivistic pieces as well. And I think thinking about the dichotomy of things is important, but also remembering that people are flexible and multidimensional, and that's important. And when we're meeting with patients and families, it's important to take more of a gray perspective. But I had a really incredible experience with a family that was from Pakistan. They, looked like me. Their children were born here. They had similar attire to like my grandmother. And when I met with them, they were just overly hospitable. And that's something that is key, quintessential to Pakistani culture, is this like overly hospitable nature. And I just felt so at home. And it was really, really nice to have that experience and to be able to actually exercise my diversity variables in that way. And something that was hard for the patient was meeting new people and meeting new providers, because it was scary for her. But when I started to speak to her in Urdu, she just kind of lit up and she was shocked for a moment. And then our rapport just like flourished from there. So I just wanted to highlight how culture can connect us, even if some things seem to be in opposition. If we just take some time to learn about the other person and approach them with curiosity and humility, we can see that we have a lot of differences and a lot of similarities, and both of those things can be respected and enjoyed. But overall, I just want to say thank you so much to everyone for joining and for being a part of this experience. And I hope that this was informative and helpful for you all. And I'm happy to take any questions if there are any, but thank you so much for your time.
All right, so we have about 1 minute left, so let's see if we have time for one question. Okay, if not, then what we'll do is reminder that after this presentation, I'm going to look at the attendance tracking, and I will email y'all your CE certificate and the program evaluation. Again, thank you so much for joining us today. All right, bye everybody.
Thank you.